Next section is heat emergencies. Next chapter, chapter number 210. Heat emergencies represent a continuum of disorder from heat cramps to heat stress that, when severe, accumulate in heat stroke. The incidence of heat-related emergencies varies with the weather, although with other factors may have a higher impact. During heat waves and severe droughts, fatality rates spike. Water, cold water. There are 8,081 heat-related deaths in the US between 1992 and 2010. But the heat wave during the summer of 2003 caused 14,800 deaths in France. In India also it caused many deaths. Mechanism of heat transfer: it is controlled by the hypothalamus. Body temperature is regulated through the delicate balance of heat production, accumulation and dissipation. Heat is generated by cellular metabolism and the mechanical work of the skeletal muscle. It accumulates from the radiation of sun and contact with hot objects. It is absorbed when the ambient temperature rises above the body temperature. As the core temperature rises, the autonomic nervous system is stimulated to promote sweating and cutaneous vasodilation. The body has several mechanisms for dissipating heat to the environment, including radiation, the transfer of heat from the electromagnetic waves from a warmer object to a colder object, conduction, radiation, conduction, which between two surfaces in a direct contact, convection, by air or liquid moving across the surface of the body, and evaporation. So radiation, conduction, convection and evaporation. Evaporation is the principal mechanism of heat loss in hot environment with sweating, but this becomes ineffective above a relative humidity of 75%. Radiation and evaporation dissipate most body heat at lower ambient temperature. The effect of wind is also very needed. Wind moves heat away from the skin by convection, but above 32.2 degrees Celsius and 35% humidity, convection does not remove heat well. This is why the use of fans alone is not effective in preventing heat stroke during periods of heat. So patient को गीला करो और फिर पंखा चला दो. When the ambient temperature rises more than 35 degrees Celsius, this is cold for us. The body can no longer radiate heat to the environment and becomes dependent on the evaporation for heat transfer. As humidity increases, the potential for evaporative heat loss decreases. So heat plus humid is the worst combo. The combination of high temperature and high humidity essentially blocks the two main physiological mechanisms that the body uses to dissipate heat, and elevated temperatures are accompanied by increase in oxygen consumption and metabolic rate. What is the response to heat stress? Controlled by the hypothalamus, the body maintains a core temperature between 36 and 38 degrees Celsius, which is 96.8 and 100.4 degree Fahrenheit. Thermoregulation fails at 35 degrees Celsius and more than 40. The physiological response to heat stress consists of four primary mechanisms, which is dilation of blood vessel, particularly in the skin, increased sweat production, decreased heat production, and behavioral heat control. So dilation of blood vessels, increased sweat production, decreased heat production and behavioral heat control. During exercise in hot environment, the heart rate increases to compensate for the decrease in stroke volume from the cutaneous vasodilation to maintain cardiac output. So patients with underlying heart disease are more sensitive to heat stress. Heat stress may also result in arrhythmias, MI and exacerbation of CHF. Elevated cholinergic stimulation to the skin results in increased sweat production, sharp increase in the rate of sweat production, cutaneous vessel dilation, and sweating increases as the body temperature rises. Sweating activation in older adults require a greater rise in skin temperature compared to young adults. So old adults can't sweat easily. What are the effect of medications? Medications often interfere with heat removal mechanism like anticholinergic agent, diuretics, phenothiazine, beta blocker, calcium channel blocker, and sympathomimetic agents. They all have their effects. Alcohol inhibits secretion of ADH, which leads to dehydration and blunts the heat avoidance response. Heroin, cocaine, amphetamine disrupt the function of endogenous endorphins and ACTH hormone involved in the heat adaptation and avoidance heat adaptations mechanisms. Amphetamine and cocaine increase muscle activity and lead to heat production. LSD and phencyclidine act on the CNS to induce hypermetabolic states. What are the risk factors? In addition to patients on the medications discussed in the previous section, population at higher risk of developing heat emergencies are elderly, young children, athletes, people with limited mobility, alcoholics. Other risk factors for exertional heat emergencies include obesity, dehydration, and vigorous exertion. So, obese, dehydrated, and vigorous exertion in the heat without proper training and acclimatization. Lack of AC and social isolation are also risk factor for non-exertional heat emergencies. Obesity, dehydration, and exertion are exertional heat, and lack of AC are non-exertional heat emergencies. Individuals with a history of heat stroke are at greater risk for another episode. Patients with congenital absence of sweat gland, progressive systemic scleroderma, hyperthyroid, and pheochromocytoma are increased risk of heat loss. What is acclimatization? Acclimation, not acclimatization. Acclimation. ACCLIMATION. Acclimation is the adaptation of the body to environmental changes. It involves a number of physiological and biochemical adjustments that allow an individual to withstand heat stresses that would otherwise result in substantial morbidity and mortality. Acclimation lowers the thermal set point in the hypothalamus. So राजस्थान के लोगों में फिजियोलॉजिकली हाइपोथर्मिया मिलेगा. Acclimation lowers the thermal set point in the hypothalamus, which triggers the onset of sweating at lower core temperatures, and the rate of sweating may double in the acclimated human. Aldosterone secretion is boosted and sodium conservation results from more efficient reabsorption from the sweat. Plasma volume expands, heart rate decreases for any given heat load, and exercise tolerance improves. Dilation of cutaneous blood vessels occurs at a lower core temperature to promote earlier cooling. Oh my god, that's literally me. Dilation of cutaneous blood vessel occur at a lower blood temperature to promote earlier cooling. In most individuals, acclimation can be achieved over 7 days to several weeks. Once removed from the hot environment, the body will deacclimate to the original physiological parameter within 1 to 2 weeks. Models of the heat injury. The pathophysiology of heat stroke is not completely understood, and there are many models. Then there is classical heat injury, exertional, and confinement hyperpyrexia. Classical heat injury occurs during periods of high environmental heat stress. Patient exertion is not required if the heat gain occurs at environmental temperatures and humidity levels that overwhelms the native heat loss mechanism. The increase in core temperature is slow, occurring over a period of hours to days. High risk population are elderly, young, physiological, pharmacological impairment and impairment of heat loss mechanism like diabetes, Raynaud's disease. Drugs like anticholinergic, diuretics, antipsychotics, cocaine cause this. Exertional heat injury usually affects individuals who are participating in athletic event or performing jobs under condition of high heat stress, मजदूर वगैरह में. Risk factors are dehydration, concurrent illness, obesity, wearing too much clothing, and poor cardiovascular fitness. In this setting, heat production and heat gain from the environment exceed the capacity of heat removal. Exercise is the most common single source of internal heat production. Without an efficient cooling mechanism, the progressive dehydration and hyperpyrexia continues to the level of cardiovascular metabolic failure. Then there is confinement hyperpyrexia. It is a special category of non-exertional hyperpyrexia, and it can occur in several circumstances, like children when left inside the cars, when stowaways are abandoned inside closed vehicles or railroad cars, and when workers are occupationally exposed to heat inside enclosed spaces. There are special types of heat illness, from minor like heat edema, prickly heat cramps and heat exhaustion, to major heat stroke. First is heat edema. It is a self-limiting process manifested by mild swelling of the feet, ankles and the hand appear within first few days of exposure to a hot environment. Heat edema is due to the cutaneous vasodilation and orthostatic cooling of the interstitial fluid in the gravity dependent extremities. And treatment कैसे करेंगे? कूल करना है पेशेंट को, resolve spontaneously within a few days. Elevation of the legs and the use of support hose facilitate removal of the interstitial fluid. Diuretics have no role. Then there is Miliaria rubra, called prickly heat. In prickly heat, it is a pruritic maculopapular and red rash over the normally clothed area of the body, also known as lichen topicus, Miliaria rubra or heat rash. It is an acute inflammation of the sweat ducts caused by the blockage of the sweat pores by the macerated stratum corneum. So basically the sweat pores are closed and they become inflamed and there is prickly. The sweat ducts become dilated under pressure and ultimately rupture, producing superficial vesicles in the malpighian layer of the skin and a bed base. Itching is a predominant clinical feature during this phase and can be treated with antihistaminic. Wearing clean, light and loose-fitting clothing and avoiding sweat-generating situation can prevent prickly heat. Calamine lotion, topical steroid, oral vitamin C can be benefit. Chlorhexidine is a light cream or salicylic acid cleaning solution provide some relief. Profunda stage of prickly heat is repeated prickly heat, which is non-itchy, Miliaria profunda, and it can advance into chronic dermatitis with Staph aureus and MRSA. Then there are heat cramps,